All right, we need to talk about oxygen. Not in the vague, hand-wavy, just turn it up way that gets patients into trouble, but in the precise, evidence-based, bedside-ready way that separates a reactive RT from a proactive one. If you've been following this series, you already know that mechanical ventilation has two primary goals. You know that CO2 is controlled by tidal volume and respiratory rate. But here's the question nobody asks out loud in clinical orientation. What actually controls the oxygen? That's exactly what we're covering today. FiO₂ and PEEP, the two settings that control oxygenation on the ventilator. What they mean, how they work together, how to set them for your patient, and why getting them wrong has consequences that go in both directions. Too low and your patient is hypoxic. Too high and you are causing a different kind of damage entirely. Let's get into it. FiO₂ stands for fraction of inspired oxygen. It is simply the percentage of oxygen in the gas being delivered to your patient, expressed as a decimal or a percentage. Room air, what you and I are breathing right now, has an FiO₂ of 0.21. That is 21% oxygen. The remaining 78% is nitrogen, and about 1% is other gases. On a ventilator, we can dial FiO₂ anywhere from 0.21, room air, all the way up to 1.0, which is 100% pure oxygen. That range gives us enormous control over how much oxygen we are delivering to the lungs with every single breath. And here is the key clinical concept. FiO₂ is your primary tool for correcting hypoxemia quickly. When your patient's SpO₂ drops and you need to act now, FiO₂ is your fastest lever. But, and this is critical, it is not the only lever. And in many cases, it should not be the first one you reach for long-term. Here's why. This is the part of oxygenation that does not get enough attention in RT school, and it causes real harm in real intensive care units every single day. Oxygen toxicity is a well-documented phenomenon. When a patient breathes high concentrations of oxygen, particularly FiO₂ above 0.60, for prolonged periods, the excess oxygen generates free radicals that directly damage the alveolar epithelium. The very structures responsible for gas exchange begin to break down. How long is too long? The research suggests that FiO₂ above 0.60 for more than 24 hours carries measurable risk. FiO₂ of 1.0 can begin causing damage in as little as 12 hours in some patients. So the instinct to crank the oxygen to 100% and walk away feeling like you did something, that is not a plan. That is a delay. The clinical goal is this. Use the minimum FiO₂ necessary to achieve your target oxygenation and get it down as quickly as the patient's condition allows. And your partner in doing that is PEEP. PEEP. Positive end expiratory pressure. If FiO₂ is how much oxygen we deliver, PEEP is how we keep the lungs in a position to actually use it. Here's the physiology. When a patient exhales, the natural tendency of the lungs is to recoil, to deflate. In a healthy lung, some alveoli stay open because of surfactant and the structural integrity of the lung tissue. But in a sick lung, ARDS, pneumonia, pulmonary edema, alveoli flood with fluid, collapse, and stop participating in gas exchange entirely. This is called de-recruitment, and once alveoli collapse, every breath that follows opens and recollapses them, a phenomenon called atalic trauma, which causes further injury with every single ventilator cycle. PEEP prevents this. By maintaining a baseline positive pressure throughout the entire respiratory cycle, even during exhalation, PEEP keeps alveoli open between breaths. It recruits collapsed alveoli back into gas exchange. It improves the ventilation perfusion matching in the lung. And critically, it allows us to use a lower FiO₂ to achieve the same target SpO₂. That last point is the key. PEEP and FiO₂ work as a team. PEEP recruits the lung, FiO₂ delivers the oxygen. Used together correctly, they protect both oxygenation and the lung itself. Here's a question I want you to sit with for a second. If you could give your patient an SpO₂ of 100%, why wouldn't you? Because getting there requires high FiO₂. And as we just covered, high FiO₂ sustained over time causes lung injury. There is no clinical benefit to an SpO₂ of 100% over an SpO₂ of 94%. But there is meaningful harm in the FiO₂ required to achieve it in a sick lung. Current evidence supports the following SpO₂ targets for mechanically ventilated patients. For most ICU patients, target SpO₂ of 92 to 96%. For ARDS patients specifically, target SpO₂ of 88 to 95%. This is the ARDSNet recommendation, and it exists precisely to avoid the oxygen toxicity we just discussed. The LOCO2 trial, published in the New England Journal of Medicine in 2020, compared conservative oxygen therapy targeting SpO₂ of 88 to 92% against liberal oxygen therapy targeting 96% or above, and found that conservative oxygen targets were associated with fewer days on the ventilator and better outcomes in ARDS patients. The takeaway? More oxygen is not always better. The right amount of oxygen, delivered efficiently with appropriate PEEP, is what protects your patient. This is where clinical practice meets the science, and this is what is going to make you look sharp at the bedside. The ARDSNet protocol established a paired FiO₂ and PEEP table that guides how we adjust these two settings together in ARDS patients. The concept is simple. As FiO₂ goes up, PEEP should go up with it. As PEEP recruits more lung, FiO₂ can come down. Here's a simplified version of the lower PEEP ARDSNet table. FiO₂ 0.30, PEEP 5. FiO₂ 0.40, PEEP 5 to 8. FiO₂ 0.50, PEEP 8 to 10. FiO₂ 0.60, PEEP 10. FiO₂ 0.70, PEEP 10 to 14. FiO₂ 0.80, PEEP 14. FiO₂ 0.90, PEEP 14 to 18. FiO₂ 1.0, PEEP 18 to 24. Notice the direction. As FiO₂ climbs, PEEP climbs with it, because the sicker the lung, the more recruitment support it needs. And as you wean FiO₂ down, you wean PEEP down with it, carefully, incrementally, watching the patient's response at every step. The goal is always the same. Achieve your target SpO₂ on the lowest possible FiO₂ with the PEEP that keeps the lung recruited without causing hemodynamic compromise. We have talked a lot about what PEEP does for the lungs. But PEEP is not without consequences, and understanding them is what separates cautious, effective management from reflexive titration. Too much PEEP, what we call injurious PEEP or overdistension, causes its own set of problems. First, barotrauma. Excessive PEEP overdistends already open alveoli, increasing the risk of pneumothorax and air leak syndromes. Remember plateau pressure? Excessive PEEP drives it up. Keep plat at or below 30 centimeters of water. That is your guardrail. Second, hemodynamic compromise. High PEEP increases intrathoracic pressure, which reduces venous return to the right heart. In a patient who is already volume depleted or hemodynamically fragile, a significant PEEP increase can drop cardiac output and worsen oxygen delivery to the tissues, even as SpO₂ on the monitor looks fine. This is why we assess the whole patient, not just the number on the pulse ox. Blood pressure, heart rate, urine output, skin perfusion, these tell you whether the PEEP you chose is helping or hurting the patient's overall oxygen delivery. The sweet spot is the PEEP that recruits the lung, maintains oxygenation at a safe FiO₂, keeps plateau pressure in range, and does not compromise cardiac output. Finding it is part science, part clinical judgment, and it develops with experience. Let's bring it all together. FiO₂ is the fraction of oxygen delivered, ranging from 21% room air to 100%. It is your fastest tool for correcting hypoxemia, but sustained high FiO₂ causes oxygen toxicity and lung injury. Use the minimum necessary to hit your target. PEEP keeps alveoli open between breaths, preventing de-recruitment, recruiting collapsed lung, and improving oxygenation efficiency. It allows you to use less FiO₂ for the same SpO₂ result. Your SpO₂ target for most ventilated patients is 92 to 96%. For ARDS, 88 to 95%. Not 100, not whatever looks good. The right number, maintained efficiently. FiO₂ and PEEP are titrated together using evidence-based tables. As one goes up, the other follows. As one comes down, the other follows. Always watching plateau pressure. Always assessing hemodynamics. And that is the mindset. Not chasing a number on the monitor, but managing oxygenation as a system. FiO₂ delivers the oxygen. PEEP positions the lung to use it. You are the one making sure both are working together for the patient in front of you. That is a responsibility worth taking seriously. In the next video, we are going deep on ventilator modes, assist control, SIMV, pressure support, and how to choose the right one for your patient. Subscribe so you don't miss it. Thanks for watching Just Breathe RT. I'll see you in the next one.